Welcome to our online session regarding Incident 2. My name is Stacy Olson, and I'm a certified professional coder with a specialty credential in evaluation and management services through the American Academy of Professional Coders. I'm also a certified compliance professional for physicians with the Board of Medical Specialty Coding and Compliance. CPT is the code set that is used to report professional medical services. It is developed, maintained, and copyrighted by the American Medical Association. Every attempt has been made to provide you with accurate and current information. However, the coding rules can and do change, and it is always the provider's responsibility to know the state and federal rules and to remain current on payer policies. Today's information is not legal advice or a reflection of any individual health system's policies or procedures. It is not instructing providers in the services they may perform and/or bill, but rather is meant to inform you of general knowledge regarding Incident 2. Our objectives for this session will be to explain the Incident 2 rule. We will illustrate the requirements to use the Incident 2 rule for billing and describe the supervision required. We'll also discuss the settings and services that can be billed under the Incident 2 rule and list the risks of billing using Incident 2. Incident 2 is a CMS rule. It states that Medicare Part B, which is the Medicare payer for professional medical claims, will pay for services that are billed by a physician or a non-physician practitioner, even if they have not personally performed that service, as long as certain criteria is met regarding the patient's encounter. When a claim is billed under a physician, Medicare allows 100% of the physician fee schedule for claims processing. Commercial payers may or may not follow the Incident 2 rule, as this rule is specific to CMS. Medicare has always understood that the physician alone was not responsible for all of the patient's care. Auxiliary personnel working in tandem with the physician provide support services considered to be part of the physician's reimbursement and represent expenses to their practices. There was very little direction regarding who could provide the support services. However, as long as the individual was qualified to do so under accepted clinical practice guidelines and state law, the concept could apply. There are many requirements which must be met in order to bill under the Incident 2 rule. The service must be one which is commonly furnished in a physician's office. The service needs to be an integral part of the physician's or non-physician practitioner's professional service and cannot be one that is usually self-administered by the patient. The physician or non-physician practitioner must have evaluated the problem and initiated a treatment plan, as well as remain actively involved in the course of the patient's treatment. This means that new patients or established patients with new problems cannot be billed under the Incident 2 rule. There must also be a valid employment arrangement between the physician or non-physician practitioner and the employee providing the service. The individual performing the service must be an employee, a leased employee, or independent contractor whose services represent a direct financial expense to the practice. The service must occur in a valid outpatient setting. The service must also be furnished under a physician's direct supervision. This means that a physician or NPP who will be billing the service must be in the office suite and immediately available to render assistance if necessary while the service is taking place. The physician who is supervising and billing for the service does not have to be the same physician who initiated the plan of care for the patient's problem. If there is not a physician on site when the service is rendered, it cannot be billed under the Incident 2 rule, and a service should never be billed under a physician who is not in the clinic while the service is being rendered. If all of the above requirements are not met, the non-physician practitioner must bill under their own name and NPI number. If all of the requirements are not met for services rendered by auxiliary personnel, the service is not billable at all. Incident to services must also meet Medicare's general criteria for medical necessity, documentation, and quality care. There are 3 levels of supervision as defined by CMS. General supervision is a service furnished under the physician's overall direction and control, but the physician's presence is not required during the service. The training of the non-physician personnel who perform the services are the continuing responsibility of the physician, as well as maintenance of the equipment and supplies. Direct supervision in the office setting means the physician must be present in the office suite and immediately available to furnish assistance and direction throughout the service. It does not mean that the physician needs to be in the room when the service is performed. Personal supervision means a physician must be in attendance in the room during the performance of the service. This level of supervision pertains to surgical procedures. The level of supervision varies depending on the service rendered and the setting in which the service is rendered in. But remember that CMS states that direct supervision is the level of supervision required for any service performed under the Incident to rule. The situations on this slide would not meet direct supervision. If the service is performed while the physician is available by telephone, it would meet general supervision, but would not qualify for direct supervision. If the physician is on campus at the hospital or at any other location than the office suite, it also does not meet direct supervision. Residents or fellows who are providing services within a residency program are not billed as Incident to. These services would be billed under the teaching physician guidelines, which have very different rules, and residents or fellows may not supervise Incident to services and meet the supervision requirement. So let's talk a little bit about non-physician practitioners, or NPPs. CMS has specifically named the providers on this slide as qualifying non-physician practitioners. A NPP is a licensed provider who can be credentialed with a payer and can bill for services without a physician present by using their own CMS provider number, known as the NPI number. Services for non-physician practitioners are reimbursed at 85% of the CMS allowed amount on their fee schedule when billed under their own name and NPI number. If the non-physician practitioner chooses to bill Incident to a physician service and meets all of the Incident to requirements, that service will be reimbursed at 100% of the CMS fee schedule when the services are properly provided and documented. This is because the bill would be submitted under the supervising physician and not the NPP. Commercial payers in the state of Washington will now treat pharmacists as non-physician practitioners for large group, small group, family, and individual plans. However, CMS has not added pharmacists to its list of non-physician practitioners. CMS, as recently as 2015, stated that pharmacists are considered to be auxiliary personnel, and therefore pharmacists do not meet the criteria of a non-physician practitioner under the federally funded plans. Pharmacists should check with individual commercial health plans to see if that payer will allow Incident to billing for non-physician practitioner services which are rendered Incident to a physician service. It is important to note that the Incident to provision of the payment percentage for Incident to services is solely for Medicare reimbursement. State Medicaid programs may follow this guidance, but Medicaid and commercial payers may reimburse non-physician practitioner services differently. Therefore, I recommend that you take the time to review each participation agreement, your provider manuals, and contractual agreements with your payers. You will also want to check the state laws to determine what is expected and allowed with the various reimbursement models. Non-physician practitioners are permitted by law and licensure to provide care and services within the scope of their individual license and consistent with individually granted privileges by a facility's governing body. When an evaluation and management service is rendered by an NPP incident to a physician service, the physician may bill the E&M code that most appropriately describes the service, but would be limited to established patient E&M codes 99211 through 99215. The service is submitted on the claim using the physician's payer ID number, and the rendering NPP's information is invisible on the claim. No modifier is required on the claim to identify that the service is being billed incident to. However, if the claim is audited, the documentation must support the service followed all incident to guidelines and limitations. When a non-physician practitioner bills under their own name and payer ID number, they may perform any level of new or established patient visit within the scope of their practice. Some practices feel that the extra 15% in reimbursement when billing under a physician is too good to pass up, and they might limit the NPP to seeing patients who can be billed under the incident to rule. However, more and more practices are realizing that offering a schedule with a combination of visit types can improve patient access to health care. Allowing an NPP to provide all types of service can increase the practice's productivity, improve access to care, and the patient's overall satisfaction. Services provided incident to are also limited by the location or setting where the service occurs. Valid locations are outpatient freestanding clinics, which would bill with place of service code 11, offices in institutions, which bill with either a place of service code 19 or 22, and in certain cases, a patient's home, which is billed with place of service code 12 on the claim form. Incident to rules do not apply to patients who are currently in an inpatient or outpatient hospital stay or to residents in a nursing facility. The bundling provision of the Social Security Act for hospitals and nursing facilities states that the payment for all services occurring in these settings are included in the lump sum payment made to the facility. The exception to this are the services rendered by physicians or non-physician practitioners which are not employed by the facility. Offices located in institutions must have an office confined to a separately identifiable part of the facility. The office cannot be construed to extend throughout the entire facility. Auxiliary staff may provide an incident to service for outpatients in the office, but not to patients that are in a Medicare-covered stay at the hospital or nursing facility. If the employee provides services outside of the office area, this would not qualify for incident to services unless the supervising provider is physically present when the service is provided. There is one exception for certain chemotherapy services which are excluded from the bundled payment the nursing facility would receive. Incident to services provided in a patient's home require the supervising provider to be physically present when the service is rendered. An exception to direct supervision in the patient's home may apply to homebound patients in medically underserved areas where there are no available home health providers for certain services. In this instance, general supervision is required, and the billing provider must order the services, maintain contact with the nurse or other employee, and retain professional responsibility for the service. All other incident to requirements must be met. A second exception applies to direct supervision in the home setting when an individual or intermittent service is performed by personnel meeting pertinent state requirements and the service is an integral part of the physician's service. Auxiliary personnel are individuals who cannot report services under their own names and who are unable to obtain payer identification numbers. These individuals could be RNs, MAs, technicians, and per CMS, pharmacists. Auxiliary personnel must have an employment relationship with the supervising provider. They can work full-time or part-time, but they are limited to billing an established E&M code of 99211, and all incident to criteria must be met. The other services that they may perform are administering injections, starting and monitoring infusions, performing blood pressure checks, and providing patient education. This is not an all-inclusive list of the services they may perform, but every billable service must be performed under direct supervision. CPT 99211 is what we think of as an auxiliary staff visit because CPT defines this E&M code as an office or other outpatient visit for the evaluation and management of an established patient that may not require the presence of a physician. It also states that the presenting problems are minimal. This is the only E&M code that can be billed to CMS for the work pharmacists do with Medicare patients. SB 5557 did not change anything for Medicare. Medicare has been very specific in stating they consider pharmacists as auxiliary staff, at least at this point in time, and that means that pharmacists are limited to charging the lowest level of E&M code for the time they spend with Medicare patients, and that all of the Incident 2 requirements must be met to report the service. The supervising physician should co-sign the documentation written by an auxiliary staff member to show that they are aware of the patient's visit and have reviewed the documentation and agree with it. At the very least, there should be a link in the auxiliary personnel's chart note stating who the supervising provider was. Documentation must support the medical necessity of the visit, the work performed, and the physician's decisions regarding any treatment plan changes or continuation of treatment. If the patient is seen on the same day by a physician, ARNP, or PA, CPT 99211 would not be reported. Only the E&M for the physician or non-physician practitioner would be reported. So what can you do to prepare your office for Incident 2 billing? You will want to have a good implementation plan that involves everyone who could affect change while maintaining compliance in the office come together and brainstorm about the best way forward. You will want to make sure that practice management staff has a very thorough understanding of the Incident 2 guidelines so that they can educate providers and other staff on the Incident 2 provision. You will want to work with your providers to create schedules for the physicians and non-physician practitioners that conform to the physical presence requirement during clinic hours and designate an individual to monitor for physical presence. You will also want to promote additional education and invite feedback from the office providers and staff. If any concerns regarding whether the practice is meeting the Incident 2 requirements are raised, investigate and take immediate action to rectify the problem. A whistleblower situation may open the door to a costly reconciliation to confirm that the requirements were historically met. Some of the risk areas for billing Incident 2 are billing for services in a setting that does not qualify for Incident 2 billing, billing new patients or established patients with new problems as Incident 2, because remember that one of the Incident 2 requirements is that there must be an established treatment plan in place from the physician or non-physician practitioner. Having unqualified staff perform the service is also a concern, as is billing the service under a physician or non-physician practitioner that is not in the clinic when the service is rendered. And you will always want to make sure that you are using the correct set of guidelines for the service that was provided, as is the case for diagnostic tests and teaching facility settings. Each year, the Office of Inspector General develops their work plan for the upcoming year. The OIG work plan identifies areas of relative risk and sets forth the OIG's primary objectives for the upcoming fiscal year. Incident 2 services have been on the OIG work plan for several years and do remain a focus. As you can imagine, this is a labor-intensive and nerve-wracking process for the physician's office. The OIG will pull the provider schedule and verify if the billing provider was in the clinic when the service was rendered. They will verify that all Incident 2 criteria was met, and they will recover any payments for services that do not meet all of the Incident 2 requirements. Here are my sources for this session. I recommend that you read them for yourselves for a thorough understanding of the Incident 2 guidelines. If you work for a healthcare organization and have a coding or compliance educator available to meet with you, I would encourage you to do so to understand the organization's policies and procedures regarding Incident 2 billing. Thank you for listening to our session on Incident 2 services. I hope that you feel confident about when it is appropriate to bill under the Incident 2 rule and the documentation requirements that will need to be met to use the CMS rule. Remember to check with your commercial payers to find out what their policy is on Incident 2 billing.